Maternal resuscitation. A legal disclaimer we put at the beginning of all of our presentations. This is for general and educational use only. Content is not intended as substitute for professional, legal, or clinical advice. We strive to keep our information as accurate and timely as possible, but we make no promises and guarantees it works for your local unique situation. As an introduction, maternal resuscitation prepares midwives for those extremely rare emergencies. I know most of our followers are independent midwives in the community setting, and we typically take care of low-risk, healthy mothers and babies, but there are situations where she has a rare genetic disorder, she has that pulmonary embolism postpartum, she has some rare situation occur that we need to be able to confidently handle the initial aspects of maternal resuscitation until EMS gets there and until they're transported to the hospital. For the nurse midwives and for the hospital-based midwives, you're going to have a higher chance because we have higher risk patients we're serving. We have a lot more interventions, complications that increase the chances of maternal resuscitation. So it's really important. A lot of the midwives are the front lines. You're the laborist. You're the midwife taking care of them. You've got to quickly get the nurses, the call lights, the obstetricians, the emergency system in play once a resuscitation, a code has occurred. So quick action is crucial. We need to be really important for airway, breathing, circulation, these things for affecting if life or death can occur. So the high demand and stress situation, we need to be able to be calm and confident. And in order to do that, we've had to practice it many times, just like we do our skills and drills for shoulder dystocia, prolapse cord, postpartum hemorrhage. Maternal resuscitation should be part of your core skills and drills in any of our settings. Recognizing maternal collapse in emergent situations. You all of a sudden have someone that suddenly is unconscious. There's severe bleeding. They're going into a hypovolemic shock. They're not breathing anymore. Their chest isn't rising and falling. You can't get a pulse. They had some chest pain. They had a stroke symptoms, and then all of a sudden they're unconscious. You have an abnormal heart rate or you don't have a heart rate. You have a low blood pressure. You don't get a blood pressure. They're starting to lose circulation. So their lips are blue, their fingertips are blue, the cyanosis is kicking in because the body is trying to protect the internal organs into the abdomen and the chest, and it's not so much worried about the brain as much and the fingers and the toes. In a cardiac arrest, the birthing person may have no pulse, breathing, or responsiveness. The midwife has to be alert to these subtle changes and quickly assess how to prioritize. Were there risk factors? Are there things to watch for? High-risk cases like in the hospital with preeclampsia that can turn into eclampsia, placenta previous C-sections, placenta abruption, postpartum hemorrhage that's now lost 3-5 liters. You're not replacing the blood fast enough. The mom can go into cardiac arrest. It could be a fluke situation, or you can see the trend of the unstable vitals making the patient go into that borderline death state. Life-saving interventions for maternal resuscitation. The midwives must learn advanced resuscitation skills based on their American Heart Association, the neonatal resuscitation program. So we want to be able to, especially if they're pregnant, our art of balancing the mom and the baby, but if the mom's not breathing, the baby, if the mom doesn't live, the baby doesn't live. So we have to prioritize the mom, and it's very hard for us. Once she's postpartum, once she's delivered and the baby is out, you hand the baby over to dad and you focus 100% on mom and stabilizing her. So if you're in a home birth center setting, your highest priority is starting resuscitation using your adult mask, getting the airway, getting chest compressions, calling 911, stabilizing her continuing oxygen flow to the heart and to the brain until EMS arrives and they can continue it. So you can get basic life support or you can get advanced cardiac life support. Most community-based midwives get the basic life support. You want to stabilize them until EMS arrives. And then in the hospital setting, quite a few of the hospitals require the nurse midwives to have advanced cardiac life support. You're not going to be the leader of those teams. Initially, you will be, especially if you saw the code, you're the one coordinating it. But as soon as higher, if the critical care doctor comes, the ER doctor comes, the obstetrician comes, you're going to become an assistant to that lead role based on the skills that you have. But if you're the first one that catches the resuscitation code situation, you got to call for help. You got to stabilize airway circulation until additional resources, the crash cart comes, the additional team is in place that has more skills to do the intubation, to do the advanced resuscitation. Cardiopulmonary resuscitation, so CPR, it's the first and most crucial aspect of a maternal cardiac arrest. It must be performed pretty quickly. The data shows the first 5-10 seconds. If you don't start for a mom or a baby getting airway, oxygen circulation, the brain death, the chances of bringing them back, especially after 5-10 minutes, you may be able to bring the body back, but the brain is just brain dead at that point. So we stress the importance of a quick response. You don't want to start resuscitation if you're alone and you haven't gotten help yet. So you're going to shake them, check if there's a pulse. If you're alone, you're going to, we have a great thing with cell phones and putting it on speaker that you can start the resuscitation as you're calling 911. If you're solo, you're doing a home birth, but usually there's some support team around. That's a good thing to pass on to dad. In the hospital setting, you're hitting the call light, you're pulling the code, you're starting resuscitation immediately. It's going to go overhead. You're going to have a lot of people helping you out in a short amount of time if it's in the hospital setting. If you're in a clinic, you're in a birth center, you're a home setting, you have to transport them to the hospital. Your time and your resources available are very different. So chest compressions, you want to do to 100 to 120 cycles per minute. So it's about 2 chest compressions per second. You're going to be pretty fast, 2 inches deep for circulation. And we always stress, especially those frail grandmas, when you're doing resuscitation, you break some ribs, Grandma can survive a broken rib. Grandma can't survive her heart not getting oxygen. And so we have to balance, like it's going to be a situation where you have to push a little deeper and you have to give a pause of recoil. Because I think when we get anxious and we get fast in it, that's why doing our CPR trainings, our skills and drills, we can really get a sense of the compressions up and down. Are we doing it too fast? Are we doing it too slow? Is it too deep? Is it too shallow? And it's going to dictate each person. You have a very tiny 100-pound mom that just had a baby, your chest compressions, her heart isn't as far away from the surface where your hand is compared to someone that's morbidly obese, has a large chest, has a bigger distance of fat and a chest size to get to the heart. So you're going to have to dictate based on the body and the situation. Airway management, you're going to tilt the head, lift the chin, jaw thrust for ventilation. If the chest isn't rising and falling, especially if they choked or you don't know the situation, you can do a blind sweep, you can visualize. But if they weren't eating and they were in the room with you and all of a sudden they passed out and went into cardiac arrest, it's typically readjusting the chin and straightening out that airway because everything gets relaxed when they're unconscious and the body, the muscle tone isn't there. So you have to stabilize the chin and the head and readjust slightly and then continue the airway breathing for them. 2-person technique is way easier than one. One can do the compressions, one can do the ventilation. But if you're by yourself, you do the best you can. You're going to get tired quickly in 2-3 minutes. You're going to want a team. You're going to circulate. Even though your adrenaline is running for the situation, we have to keep our mind calm. We have to make sure, am I doing the right pace? Am I going too fast? Am I going too slow? Communicating with the team, calling for additional resources. What supplies do you have? What are the priorities? What other situational things are going on? Like if it's a postpartum lady, is she also bleeding out? So she's going to need some fluid replacement. What is potentially causing this cardiac arrest? And it may be a pulmonary embolism. It may be a rare genetic condition. It may be something you can attest to. We've had bleeding. Her vital signs are unstable, and now she's went into cardiac arrest. You've got hypovolemic shock occurring. So if it's during pregnancy, especially the 3rd trimester, you have to tilt them on their side, put a pillow, compress. You can't have the baby and the uterus relax right over that big venous cava, and that impairs the blood flow greatly. So sometimes we get into emotion. I think midwives are better at this because we do our tilts all the time during prenatal visits when the mom gets a vagal response lightheaded, but EMS isn't as familiar. So if you are in a home birth center setting and EMS comes and takes your patient and you've been resuscitating and you had them at a tilt, You need to make sure when they switch them over to their cart and they continue the resuscitations that tilt is still in place. So there's little things that are really important, especially when they're pregnant and have a large uterus, putting weight on those big blood vessels in the back. Postpartum hemorrhage is a good, important aspect, especially when maternal resuscitation is required postpartum. If she's had bleeding, maternal death from postpartum hemorrhage is the number one thing across the world. We have to respond quickly. We have to do active management of late postpartum, that third stage, placenta delivers. Depending on your setting, I get it with physiological birth. But if she's got risk factors, she's got anemia, she's got a history of a postpartum hemorrhage, she's got risk factors that she should be in the hospital setting, and active management of third stage is appropriate with Cytotec, TXA, Methergin, Hemabate. This is how we save lives. But if there are situations where there were no risk factors, you're in the home setting, you're a direct entry midwife and you legally can't carry medications, you only have your herbs, you're going to have to just utilize the best you can for management of postpartum hemorrhage. But this is a good chunk of where the maternal resuscitations come from, and the maternal deaths is from the excessive bleeding. So you want to do a uterine massage, you want to get the clots out, you want to make sure there's no retained placenta parts, you want to determine the pathway of why they're bleeding. Are they bleeding because the uterus is boggy, it's not very firm? You need to give uterotonics that are going to firm up the uterus. So you're going to give the oxytocin, pitocin, the misoprostol, Cytotec. You're going to give the things to firm up the uterus, the Methergin, the Hemabate. If you're worried about clots, the placenta didn't completely deliver, it delivered in sections, you may have to do a manual exploration of the uterus to remove the excessive parts, because if you have clots and you have retained products of conception, you're going to not be able to allow the uterus to firm up and clamp on those blood vessels. If she has a placenta accreta, a percreta that you didn't know about, it's going to make things very, very challenging. A cervical laceration, a sulcal tear in that post fundal aspect where it's deep and it's arterial and you think it's coming from the uterus, but you have to visualize. You have to visualize the vaginal vault. You have to look at their cervix. You have to have the right tools, the lighting, the equipment. That sometimes is challenging in the home birth center setting. But if her uterus is firm, you know the placenta is intact, you know there's no clots, you've already done manual exploration, you should be looking at those missed lacerations, perineal lacerations, and those cervical lacerations to see if that's the place of the bleeding source. In the hospital setting, you're going to do fluid replacement and you're going to do blood products. When they're losing blood faster, then you can replace and you can stabilize. A lot of times in the hospital setting, they'll do a tamponade, they'll do a Jada balloon, they'll do a DNC, they'll do emergency exploration surgery, they'll take them back to repair the cervix in the OR. There's a lot of different ways depending on where the pathway of the bleeding is coming. So we want to stop the maternal resuscitation from occurring. And the main reason that we get maternal resuscitations is that postpartum period from a postpartum hemorrhage and hypovolemic shock. Oxygen and airway, you want to be able to, during a resuscitation, clear airway, especially during respiratory distress. If they have an amniotic embolism, they have maternal aspiration, maybe they ate recently and they got in a car accident and they had to have surgery and they're pregnant and they have aspiration into their lungs and they can't breathe, and during the OR and the surgery anesthesia, they're now coding. Like, there's different components to what can cause maternal resuscitation, but we're talking about as midwives in that front line. Most of the midwife followers I have are home birth center, and then some that are in the hospital setting. You're going to be the first line. You need to get that mask going. You need to get, if there's no mask, you're going to have to do yourself as that airway. You're going to have to do chest compressions. Intubation is usually EMS, hospital setting, more advanced skills. Your goal as the midwife is to continue getting that heart pumping the blood throughout and getting the body oxygen. That is your primary goal until the other resources get there. Emergency transport and coordination of care. It is So important. Minutes matter during maternal resuscitations. What is within your scope? As soon as you have in the out of hospital setting a maternal resuscitation, you should be calling 911. The dad can help coordinate. You and the birth assistant are doing the maternal resuscitation till EMS can arrive. There are small community hospitals that they don't have enough blood, they don't have enough resuscitation resources, equipment, and they have to transfer out as soon as they can stabilize them to the best of their abilities. So it's not always, sometimes it's hospital settings, especially after a resuscitation. Maybe they don't have a critical care system that can manage that post resuscitation needs like a higher acuity facility can do. So you always are doing that risk benefit analysis of where are we at in the resuscitation? What resources do I have in my setting? What skills, what knowledge, what team members, what supplies? And is it the best fit, or is there another place we can go to help increase the chances of survival from this maternal resuscitation? Emotional support and communication. When it's happening, it's super stressful. The midwife is going to communicate with the family members that are present a little bit, but the highest priority is going to be the airway, the breathing, the chest, communicating with EMS, making sure that the mom is getting oxygen and the heart is pumping. And there is so much studies with codes that you don't want to kick families out. It used to be the culture, especially in the hospital setting, that one nurse would take family away. And they're finding with the studies, the grieving process, the risk of liability to keep the family present. Obviously, if it's a tight space and there's safety issues and you need the skilled people coming in. But if you have the room, giving them the choice to stay or go has a huge impact on that emotional support. There's a lot of communication that happens, debriefing with your colleagues and the family after the maternal resuscitation. But while it's happening, you have to prioritize giving the care and then having them participate. Dads and family members, when you're in the out of hospital setting, are a massive support. Hey, grab me this out of my bag, call 911 for me, put it on speaker, give them your house address, answer the things you can answer, and I will, in between giving the breast and the chest compressions, be able to communicate to EMS. So you have to look at, you make them part of, they want to help. They see this traumatic situation. They see their loved one has just coded and is dying. They want to help any way possible. Post-resuscitation care and monitoring. So as midwives, typically we're not the lead care provider anymore. They're outside of our scope, but we're still part of the team. We're still, depending on your setting and how your relationship is, when it's a home birth center midwife, the patient's going to be in the hospital at this point, and you're a guest, you're a visitor. You may or may not be able to do postpartum care depending on how complex the situation. You're going to be an aspect of the higher risk obstetrical team, but you still have immense value. The nurses are mostly going to be the ones following up with the shock, the organ dysfunction, the bleeding, the damage that has occurred from that. But we can help with breastfeeding. We can help with her emotional understanding. We can help with the family taking care of the baby and getting them connected with other mothers that have milk that can be donated for this baby, because it was really important to this mom that this baby never got formula. And we can try to help pump while she's in the ICU and is in a medical induced coma. Like, there's little things we can do as a midwife to help with that experience and to help with the mom and the baby and the community and the family dynamics during these situations. Ongoing education training, it's so important, because things are rare does not mean most people do not keep up with the skills and training. We do BLS and ACLS and NRP twice a year. Few places have the proactive approach to get you more training than every 2 years. The studies show so much. If you don't repeat it every 6-8 weeks, you lose the skills quickly. And you don't want to be, when you're tired and exhausted and you're rushing and you're in real time, you want it to be like the back of your hand. You want it to be strong. You want it to be in sync. That's why we practice all the time: shoulder dystocias, prolapse cords, postpartum hemorrhages, uterine rupture, especially after a VBAC. Like, we're practicing these rare emergencies, and maternal resuscitation should be part of that skills and drills rotation. So as an overall conclusion, Maternal resuscitation is something that nobody wants to be part of, whether they're pregnant, they're postpartum. It is a high stress, scary situation, but it is our job as midwives and the healthcare providers and the birth team to be that critical access to starting the chest compressions, the airway breathing assistance, to stabilize and get them so that they're getting oxygen, they're getting blood flow until EMS arrives, till you hit the call light, the code, and you have additional support in the room depending on your setting. But you are many times going to be that front line because we are doing direct care. And we have to get the team, and we have to be part of the resuscitation team based on the skills, knowledge, and resources we have. But when you're doing more independent midwifery skills, you're doing it in more birth center, home, clinic setting, you have to have more skills than a midwife in the hospital setting does with resuscitation, because they can very quickly get respiratory therapists, ER doctors, critical care doctors, nurses from critical care. They have different skills at their fingertips than you do in the community-based setting. And so your skills have to be different, and you have to work closely with EMS, because if you're absolutely amazing and then EMS takes over on a mom or a baby during resuscitation and they don't know what they're doing, you're still going to have a bad outcome, and everybody's going to be linked to that trauma, that litigation, that poor outcome for that mom or baby. So with maternal resuscitations in particular, you want to do skills and drills with every aspect of your transport community services with your scope.